Good afternoon, everyone. Thanks for logging on and joining on. So, Paula is my name. I'm one of the Spinal Liaison Nurses in the Rehabilitation Hospital. Some of you probably know me. Been in the role now for nearly 3 years, and my predecessor was Liz, who some of you might know also. So, SAI kindly invited me down to give you, it's quite a brief presentation on autonomic dysreflexia, which some of you will have heard of and be familiar with. So as we said, if there's any questions, if you can put them into the box, I'll try and answer them all at the end. And anything that might come to mind when we're finished, I have no problem if you want to send them on to the girls here in spinal injuries, and they can email them across to me and I can answer you individually if that was more comfortable for you. How do I move on here now? This one? Sorry, bear with this now. Okay, thanks a million. So what is autonomic dysreflexia? So it is a medical emergency which occurs in individuals who have a spinal cord injury at the level of the 6th thoracic vertebrae or above. So 6th thoracic vertebrae, so T4 is around nipple line, so just slightly below nipple line will be your 6th thoracic vertebrae. So if your injury is at that level or higher, it could mean that you are susceptible to developing autonomic dysreflexia. It's characterized by a sudden rise in blood pressure and a low heart rate, although occasionally we do see individuals who have a fast heart rate. So autonomic dysreflexia is unique to spinal cord injuries. After I did this presentation on a previous occasion, one of the attendees contacted me to query whether he might have this condition. He doesn't have a spinal cord injury, he had another condition. And I was able to assure him that he would never suffer or have any episodes of dysreflexia. Only those who have a spinal cord injury would be susceptible to dysreflexia. What is it? It's an overactivity of our autonomic nervous system. It's a very complex condition, but what you need to know is if you are susceptible to it, if you get it, how to manage it. You don't really need to know the whole science behind it, but it's a good idea to have a general understanding of it. So what causes it? So in about 88 to 90% of cases, it's caused by the bladder, and it's caused by bladder distension. And that would include urinary retention due to a blocked catheter, failure to empty your catheter bag. So if your catheter bag overfilled, that would cause backflow of urine into your bladder, and your bladder would fill and it wouldn't be able to be released. Can be caused by urinary tract infections, by bladder or kidney stones. Sometimes when people are having diagnostic interventions such as urodynamics or perhaps flow rates or maybe a cystoscopy, they might get dysreflexic, and sometimes bladder installations like bladder washouts could set off dysreflexia as well. So things to watch out for there is, you're emptying your catheter bag regularly, you're drinking well to prevent urinary tract infections. Your tubing is not kinked, it's not pulling. So the use of Catheter. And then just to be aware that if you had to go into hospital for any diagnostic intervention to do with your bladder, that you would alert the clinicians that are attending to you that you may get dysreflexic. Bowel distension then is the second most common cause. The difference between bowel distension and bladder distension can happen quite quickly, whereas the bowel is a more slow burner with dysreflexia. So examples of what can happen in the bowel, what can cause it is bowel impaction, so severe constipation, digitorectal stimulation, suppository insertion or enemas. Hemorrhoids can cause it, and anal fissures or tears. Other causes then could be acute abdominal conditions, and by that I mean if someone were to develop appendicitis and perhaps didn't have sensation, it might set off dysreflexia. Skeletal fractures, we had a gentleman in the hospital who started to get dysreflexic Couldn't find out the cause of it, and he told us then that he had banged his leg off his bed, and when we x-rayed his foot, he actually had a fracture, and that was setting off his dysreflexia. So sometimes skin-related disorders such as pressure sores, ingrown toenails, and burns. And we're seeing a little bit more of people developing burns from heated seats in cars, so just something to be aware of. Sexual activity, so particularly in the males at ejaculation, they can develop dysreflexia. Labour then for the females and delivery can cause it also. So how would you recognise if you had dysreflexia? So the signs and symptoms. The first sign is nearly always a severe throbbing headache, but we do have patients who never get a headache. Flushing or blotching of the skin, and that would be above the level of their spinal cord injury. Profuse sweating above the level of the injury, goosebumps lower down, blurred vision, nasal congestion, shortness of breath. Some people can get very apprehensive and really anxious, high blood pressure and a slow heart rate. And I did say earlier that some people do get a high heart rate. So the first signs, as I said, is generally the headache, the flushing of the skin, the sweating, and the goosebumps. The blurred vision and the nasal congestion, the shortness of breath, they're usually more later signs of dysreflexia. Just to point out there that a normal blood pressure in somebody who has a high spinal cord injury, and by that I mean above T6, normal blood pressure is lower than the general population. So it's about 15 to 20 milligrams of mercury lower than people who don't have a spinal cord injury. So what can happen, and it's been reported to me on many occasions at this point, that people know that they're dysreflexia, they're recognizing that they have dysreflexia, and perhaps they need their catheter changed, and they've presented themselves either to their GP or to local accident and emergency department. And they go through triage, and the triage nurse checks their vital signs, and their blood pressure is perhaps 130/90, and that would be quite a normal blood pressure for the general population. But for somebody with a spinal cord injury, that could be quite a high blood pressure. So really important for you to have an idea of your baseline blood pressure. So on examination, blood pressure could be 20 to 40 milligrams of mercury, and that's how we measure blood pressure. We measure it in millimeters of mercury. So if you're talking to any of your GP or your public health nurse, or perhaps accident and emergency, and they say millimeters of mercury, that's what they mean. So it's 20 to 40 millimeters of mercury above your baseline, or systolic, which is the higher blood pressure, greater than 150. So it's a good idea, as I said, for anyone who has a spinal cord injury above T6 to know their baseline blood pressure. And you can buy really cheap blood pressure monitors now in most pharmacies, and the likes of Lidl and Aldi do them when their specials come around as well, and they're really reasonable. It's a good idea to have one in your own house. Autonomic dysreflexia is a medical emergency, and I have that in bold there. And I don't put that there to scare people. It's just there so that you know if it's left untreated, it can become a medical emergency. But you do have time to find out the cause of it and to try and eliminate the cause of it. If it's left untreated, and that's really important because people get quite frightened by this. If it's left untreated, it can lead to a stroke, a cerebral hemorrhage. So a cerebral hemorrhage could be a brain hemorrhage. Seizures, which are, you might know somebody who perhaps suffers from epilepsy and they have those seizures, so it can lead to seizures. Myocardial infarction, which is a heart attack, or even death. But what I will emphasize there is that if it's not treated. So what do you do if it happens? So assist the person to sit up if possible and to call for help, because if you're alone and you feel you're dysreflexic, you probably will need assistance and you probably won't manage it yourself. So if you were lying in your bed, and you have the ability to sit yourself up, do so. Call for help. Loosen any tight clothing. So for example, if you're wearing an abdominal binder, tight jeans, tight clothes, loosen them, just open the waistband, undo the abdominal binder. If the leg straps on your catheter bag are very tight, undo those, and you could take your shoes off also. Pop on your portable blood pressure monitor and switch it on and let it start to take the blood pressure. And the next thing you're going to do is look for the cause. And obviously, if you can't do that, you will need help to get somebody to do that for you. So the first place we go to would be the catheter, because we now know that the catheter is the most common cause of dysreflexia. And as I said to you, it's about 88 to 90% of cases it is caused by a blocked catheter or kinked tubing. Check for the bladder. So we're going to check to see if the bladder is draining, if the catheter is draining, if the bag isn't over full. So we want to empty the catheter bag. If you have a suprapubic catheter and somebody, perhaps your family member, are with you, you could do an in and out catheter, what we call an intermittent catheterization. If somebody who's with you or your family member is not able to do that, don't worry. You're checking the bladder, you want to empty the bag. Check for kinks in the kinks in your tubing. Are you lying over on your catheter bag? Is the catheter itself kinked, perhaps just at the cat secure, or is the catheter, the leg tubing, perhaps if your legs are leaning against the foot plates of your chair, perhaps the catheter bag is caught there as well, so check that out as well. Just some people would do a bladder washout as well if they felt their catheter was blocked. And if you have a bladder washout there and you feel your catheter is blocked, you can absolutely try to do a bladder washout. It may or may not undo the blockage. If it doesn't and you have a suprapubic catheter, don't remove the catheter. You want to contact somebody who can come and help you change the catheter. And if that's not feasible, we need to get ourselves to somewhere like an accident and emergency department or a GP surgery if they have the ability to change the catheter. So if it's the bowel, as I said to you, if it's the bowel, it doesn't happen quickly. Most people are on a daily or on an alternate day bowel program, and you'll know yourself whether you're having a result. So perhaps if you haven't had a result on Monday and you come to Tuesday or Wednesday and you still have had no results, so you know the red flags are there straight away that you know that I might need to intervene here. So it doesn't creep up as quickly as the catheter does. If you hadn't had a result for a few days, you might need to increase fiber in your diet. You might need to increase your oral laxatives. But what you do if it is the bowel that's causing it? So we need to check that there isn't a lot of hard stool present in the rectum. So what we're going to do is do a rectal check. And if there is stool in the rectum, we're going to remove it gently. And you can use something like an Instilla gel, which is a numbing gel. And what that does is just dampens down the nerves there to decrease potential stimulation that could cause the blood pressure to increase even more. If you don't have Instilla gel, that's okay, don't worry. Still do the rectal check and check that there isn't a large fecal mass just in the rectum that's causing the dysreflexia to happen. So this is a leaflet. It's a really busy leaflet. We have it in the hospital and I can send a copy to anyone who would need it. We use that for a lot of healthcare professionals when we're doing training on dysreflexia, but a lot of patients have used it also. So down along, it's my left-hand side. You'll see the causes there. So we have the bladder, we have the bowel, we have skin, and then the other possible causes of it. And just to draw your attention to the box there on the bottom left-hand side, which is the emergency treatment for autonomic dysreflexia. And we're going to go into that in a little bit more detail as well. The rest of it, you'll see it goes from the wheelchair and the person on it. So if you start at 1 and work your way around, it just goes through the autonomic nervous system and the sympathetic response. You don't actually have to know that. That's really what we would use for healthcare professionals, explaining to them what dysreflexia is about. But handy to have a copy of this, perhaps in, your house if you had to go to a local A&E department. Because although you might tend to go to a local accident and emergency department, but you might come across a healthcare professional who has never dealt with autonomic dysreflexia. And, that's not a reflection on them. Some people go through their entire medical career and never come across dysreflexia, or perhaps never come across somebody with a spinal cord injury. So it really isn't their fault. So the more that you know about this condition and the more that you can explain it to the clinicians, the better that it will be. So I want to go back now, to this bottom left-hand corner, which is the emergency treatment. So if you believe you might be dysreflexic or you're getting symptoms of dysreflexia, you need to call for help. Sit upright and lower your legs. So we're doing the direct opposite to what we would do if somebody was feeling faint. Somebody's feeling faint, you lie them down and you raise their legs up, and that's you want, because we want to higher their blood pressure. We want to do the direct opposite, and we want to lower it. We're going to sit them up and lower the legs. Loosen any tight clothing, as I said, abdominal binders, leg straps and catheters, tight jeans, tight trousers. Just open the waistband. If it's an elasticated waist, just pull it down slightly so the abdomen can come out and relax a little bit more. Pop on a blood pressure monitor and leave it on and check the blood pressure. So the first place we're going to go to is the bladder. We're going to check the bladder, check that the tubing's not kinked, the catheter is not blocked, the bag is not over full. Second most common cause is constipation. And I say you'll have a general idea whether you're constipated at that point or not. And if you feel that you might be constipated, you could ask somebody to do a rectal examination to remove hard stool that might be in the rectum. So you've done all of that and you still don't know what's causing your dysreflexia, and your blood pressure is actually starting to rise a little bit. So what we need to do is we need to treat the blood pressure, because we don't want the blood pressure to continue to rise. If we don't treat it, it will continue to rise. So the symptoms are persisting. We're still not sure if it's the bladder, or we're not sure if it's the bowel, and sometimes we aren't sure. So then we have a drug called nifedipine. So the dosage that is recommended for treatment of dysreflexia is 10 milligrams. And it's what we call a bite and swallow capsule. So it's a capsule, you'd all be familiar with capsules. You take it into your mouth, you need to bite it to release the liquid. And the medication gets absorbed through the oral mucosa, and then you swallow it down. It doesn't taste very nice, but you can take a drink of water afterwards. And that immediately, because it's already been absorbed in the oral mucosa, it immediately starts to work on the blood pressure, and it will lower the blood pressure. And that buys you time then to either contact your GP, community intervention team, and or the emergency services if you need to get yourself to an accident and emergency to get your catheter changed. If you've taken your nifedipine and your blood pressure is not settling, so the blood pressure has not dropped after you've taken the nifedipine, it would be advisable to get yourself to an accident and emergency department in case there's something else causing it. I've never seen nifedipine not work. It's always worked for me. And in fact, some people don't like taking it when they get dysreflexia because they get a rebound hypotension, which is a low blood pressure, which sometimes means they can't get up that day or can't get up till the evening time because their blood pressure is low. And if you remember, I said people who have high thoracic and cervical spinal cord injuries, they work off a lower blood pressure than the general population. So if your blood pressure is low and you take nifedipine to manage dysreflexia, the dysreflexia gets resolved because perhaps the catheter gets changed, or that the catheter becomes, you can unblock your catheter. You might be very hypotensive or have a low blood pressure for the evening. So when you get up, you might feel a bit lightheaded. So that's just something to be wary of with the nifedipine. But if the blood pressure is not settling, you absolutely need to take nifedipine. So that's just what I said. If the symptoms persist and you don't know the cause, or you're not sure what the cause is, take the nifedipine 10 milligram capsule. So really it's about prevention of dysreflexia. So how do we prevent it? So to keep our bladder and our bowel healthy, so regular bowel program, and emptying our catheter bags regularly, not allowing them to overfill. If we have a lot of sediment in our urine, perhaps we need a bladder washout. Attend your urology surveillance appointments. Routine skincare. Check your skin when you get up in the morning, check your skin when you go back to bed, so that if you see any break in the skin integrity, that you stay off that area until it's healed. Nail care, particularly toenail care, really important. Ingrown toenails are one of the causes of dysreflexia, so you need to be careful of that. And I think anyone who has a medical card is entitled to chiropody services, so that's something to bear in mind. Avoid extreme hot and cold. So I said to you about the heated seats, be careful of those. Sometimes people who suffer from dysreflexia, and some people will never get it, and some people are more symptomatic. If they go from a very warm house out into a very cold winter's day, they may get, goosebumps, they may get symptoms of dysreflexia, but it generally settles. But it is something that can happen. Take your prescribed medications. If you're concerned, consult your GP or the NRH or myself. And in conclusion then, autonomic dysreflexia is recognised as a medical emergency. So if you're concerned about it, don't think, oh, I won't contact my GP or I won't contact the accident and emergency hospital. They're too busy and they, may not know how to treat this. If you have concerns, do contact them. Really, I suppose we're trying to promote knowledge about autonomic dysreflexia. Anyone who's been through their rehab in the NRH or indeed anywhere else, I'm sure will have come across the term. Early recognition, really important. So if you feel you're starting to get dysreflexic, check your catheter quite quickly. Don't leave it because it could be something that is just a kinked tube. You unkink it and the symptoms will go away. So once the cause is removed, once the stimulus is removed, the AD will go away and it goes away as quickly as it came. Prompt treatment and to minimize complication. And I suppose be aware is to be prepared. That's it. That's my contact number and my email. If anyone, doesn't feel comfortable asking a question on this forum, I don't have a problem. If you want to drop me an email, I can answer you directly. And that's my office number there across in the NRH. Thank you. I'll hand it back to Hilary because she's our tech genius here. Yeah. I've got to stop sharing and we can see if there are some questions here. Okay, so there's the first question. I'll just read the question if that's okay. So district nurse and service providers have requested my GP write me up for a tablet for autonomic dysreflexia. I've spoken with my GP, but he's not prepared to prescribe it. I've also requested from my urologist, what can I do? So this is a common enough, people come across this where their GPs just aren't familiar with autonomic dysreflexia and you're saying to them that you want a prescription for an nifedipine 10 milligrams bite and swallow capsule. And the GP knows that perhaps you're a high spinal cord injury and they know that you have possibly a low blood pressure. So he's not prepared to, or she is not prepared to give you a prescription for the nifedipine. If that's the case, drop me a message. I can drop an email to your GP and just let them know, and I can send out the information leaflet to them and they'll see the treatment on that. And failing that, then I can get one of the consultants in the NRH to do it if they're not prepared to accept it from me. I know most of the urologists who treat people with spinal cord injury would be aware of autonomic dysreflexia. So I suppose I've never come across a urologist not being happy to prescribe nifedipine. But again, if you have difficulties and you want me to be a liaison between the two people, I'm happy to do that. Okay, so over 25 years ago, I was prescribed medicine by a urologist for autonomic dysreflexia. Not the same now. To take over a month, which eliminated my autonomic dysreflexia for a long time. Can similar be done now? So no is the answer to that. We don't routinely treat people for dysreflexia. We only treat it when it occurs. Because if we were to, the treatment would be something to lower blood pressure. And if we were to administer an antihypertensive to somebody who doesn't have hypertension and has a spinal cord injury, we'll lower their blood pressure, will increase their risk of falling, or perhaps falling out of their wheelchair, or getting, a fainting episode when they're in their wheelchair. So no is the answer to that. There's no medication that will be taken as a prevention for dysreflexia. It would be just a treatment when dysreflexia occurs. Okay, so Stephen. I have a portable BP machine and I have suffered AD a few weeks back and the machine won't read my blood pressure. Should I get another machine? So Stephen, just to make sure, so the cuffs on some of the portable blood pressure machines are really sensitive. So you need to make sure that the cuff fits your arm correctly, and they all err on the small side. I mean, I've big arms myself, so you need to make sure that the cuff actually fits your arm properly and that you follow the instructions on the the cuff itself will generally align itself to a different part of your arm, so make sure that it's on correctly. Sometimes, and even with the sophisticated blood pressure machines we have in the hospital, if the blood pressure is fluctuating quite quickly, sometimes it won't read the blood pressure. So it can happen, but I would safely say, Stephen, that's a cuff problem and not a problem with the BP machine. And you may need to just maybe go up the cuff or maybe lower the cuff size down as well. But I'd imagine probably a bigger cuff is probably the answer to that. Can you get AD if you're regularly using SCI to empty the bladder? Very unlikely to get AD if you're doing intermittent catheterizations, because if you think about it, you're regularly emptying the bladder. You're not allowing the bladder to fill or stay full for any long period of time. So most people who do SICs do them 4, 5, 6 hourly. So it's unlikely to get dysreflexia. But if you did get dysreflexic, I suppose, you know, in medicine, there's a never say never type of an approach, because there's always exceptions to every rule. But if you did get symptoms of dysreflexia and you were using SICs, just pass a catheter, because you'll empty your bladder. But just to be aware that you could be dysreflexic, not from your bladder, you could be dysreflexic from your bowel or something else. So that's just something to be aware of. Paula, it might be good to mention that if anyone is attending A&E at the moment, to bring as much information as they have about their condition from their consultant or doctor, because last week I attended A&E and it was like they hadn't a clue about any of my medical conditions because they couldn't access their system. Oh, that's such a good point. And I'm really glad you brought that up. And this has been on the news as well. If you have to go to A&E for dysreflexia or anything else for that matter, and you actually have on a piece of paper your hospital number from that hospital, bring it with you. If you have any information on dysreflexia, bring it with you. There's no internet. We've no internet in the hospital at all. So if I need to get a chart, and this is the same in any of the hospitals, I can't, you know, email medical records unless I have the hospital number. Internal email is back up and running with us, but not in other hospitals. So if we don't have a hospital number, we can't access a healthcare record or a chart. And that just leaves people back to pen and paper with no information. So absolutely, I'm so glad somebody put that up. Thanks very much. Definitely bring anything you have with you. Is it only when your blood pressure is too high? Because mine keeps dropping and I feel so lightheaded. I got physio Sinead from outpatients to check and my blood pressure is very low. Is there anything I can do about this, or is it a different thing altogether? So it's a different thing altogether. So as I said to you, people who have high spinal cord injuries, whether they're complete injuries or incomplete, they can suffer from a very low blood pressure. So dysreflexia will never cause low blood pressure, it only causes high blood pressure. So if your blood pressure is dropping, it's either as a result of your spinal cord injury, or perhaps, you know, maybe dehydration can cause low blood pressure as well. So keep your fluids up. And if you're continuing to monitor your blood, keep an eye on your blood pressure as well. So check it out and keep a record so that when you go to your GP, you could tell your GP your blood pressure is dropping. And there are medications that can be given for low blood pressure to stop that lightheaded feeling. And that's an awful feeling. Because you can feel quite nauseated as well, and you just don't want to do anything, you don't want to go anywhere. It's a terrible feeling. So if that's something that's continuing, you know, keep a diary of it and perhaps mention it to your GP as well, because as I said, there, you know, that can be regulated with medication if needed. But keep your fluid intake up, and in this warm weather as well, you know, you do need to drink quite a lot. Dehydration can cause that blood pressure to be quite low as well. So that's something to be aware of, but it's not dysreflexia, that's the main thing. Can AD result from other issues other than bladder or bowel? Example, a burn or a bruise? Absolutely. Karen, how are you? So, you know, any sort of what we call a noxious stimuli, which is a painful stimuli, can set off dysreflexia. So if you had a burn, you know, even a sunburn, you know, on your feet, I've seen a patient in NRH get dysreflexia from to really, really sunburned feet. So yes, absolutely. So the other conditions generally would be anything to do with skin integrity. If the skin integrity is broken, be it a pressure sore, be it a burn, a bruise, a cut, that can absolutely cause dysreflexia. Did you say we should bite and chew the AD medicine? Yes. So it's a capsule, so you need to put it into your mouth, you need to bite it. Years ago, we used to pierce it with a needle and squirt it into the mouth, but that's stopped now because of needle stick injuries. So you put it into your mouth, you just bite it. As soon as you bite it, it releases the liquid, because by doing that, you're absorbing the medication into your oral mucosa straight away, and it immediately will lower your blood pressure. And that's why for people who have epilepsy and that, we're now giving anti-epileptic medication, and anti-migraine medication is given directly into the mouth, into what we call the buccal cavity, which is the cheeks cavity, because there's a really high absorption directly into the bloodstream from that. So yes, bite and swallow them. If you take it without biting and swallowing it, it will work, but it will take longer to work. Sean, hi Paula. Is it common to have intermittent low-grade attacks of AD, such as blood pressure, such as a blocked nose, it can last 20 minutes and then fade away? It's not that common, but I would say it's possible. So the blocked nose is something that some people suffer from. Not everyone gets a blocked nose, and it's usually it's not usually the first sign of dysreflexia. But as I said to you, in medicine, we never say never. People get different symptoms that are completely normal for them, but the next person who has the exact same level of spinal cord injury doesn't get it. So it could be dysreflexia. Check your blood pressure is what I'll say to you. And people, I'm glad you put that in there about the low grade. So some people have low grade dysreflexia a lot of the time, and maybe their catheter is not blocked, but maybe the catheter has moved slightly, or it's rubbing, or that's why the cat secure is important as well. Don't let your catheter be loose. Keep it secure. And some people do get that low grade attack of dysreflexia. So yes, Sean, that is possible. Suppose you thought you were developing AD but didn't have access to a BP monitor. Is it dangerous or unwise to take the AD medicine without knowing your blood pressure? Kieran, it's not dangerous to take it. The only problem that you may have afterwards is that you may feel very lightheaded and a little bit nauseated. So low blood pressure can cause that horrible nauseated feeling. You don't have access, like you go out, you're gone out for coffee or you're gone for lunch, well, which we're nearly back to doing. But and you don't have access to a blood pressure monitor, and you're fairly certain you're developing AD, absolutely, you can take your nifedipine. But always check for the cause first. So don't take your nifedipine, if you're going out or you're at home, whatever the case may be, and you're sure that your catheter is draining well, check for the cause. Just check that the catheter is not blocked. Check that the tube's not kinked. Check those things before you take it to avoid that sort of rebound hypotension. But it's not dangerous to take it, no. Okay, so when you say from T6 is above, mine is T8, so am I in that category? No, Governor, very unlikely that you would be. So we say T6 as a definitive marker. Very, very occasionally, and I'm nearly 30 years working in spinal injury, I've seen a T7 get it. I've never seen a T8 suffer from dysreflexia. So I would say no, you won't be in that category, no. And Kieran says, can some people with SCI never experience AD? Absolutely, yes. Not everyone will get it. I've seen people with catheters blocked that haven't drained for perhaps an hour, 2 hours, 3 hours, and they haven't got dysreflexic. I don't know if the catheter blockage had gone on longer. Would they have suffered from a dysreflexia episode? I really don't know, because we obviously took away the cause at that point. But yes, some people never get dysreflexia. And if your injury is incomplete, it actually lessens your risk of having a dysreflexic episode, but it doesn't eliminate it entirely. No more questions. Will this be recorded? How quickly does AD develop? Kieran, it develops quickly, particularly if it's related to the bladder. So if the catheter blocks off, or that urine can't be eliminated from the bladder for whatever reason, be it a blocked catheter, an over full drainage bag, kinked tubing, perhaps sediment, that kind of thing, it would develop quite quickly, and it can develop 10 minutes. I wouldn't put a time. I'm loath to put a time frame on it because everyone is different, but yes, it can develop quickly.
I think that's the end of our questions. So I want to say thank you very much to Paula for coming all the way over from the
I know
NIH.
we had to come over here to SAI because we've no internet in the hospital, so I ran down. But just to say, thanks for joining, and just it's great, and it's great to have it's great to have the interest from you guys, and that's what it's all about. It's all about sharing information. But if you have any questions that perhaps you just don't feel comfortable asking here, my email's there. Please email me, call me. Don't be